Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we focus on a key community affected by hepatitis B virus infection, Asian American people. I'm joined today by Dr. Joseph Lim, Professor of Medicine at Yale School of Medicine, Dr. Mindie Nguyen, Professor of Medicine at Stanford University, and patient and nurse Jennifer Wild. They will discuss their strategies to overcome barriers to HBV care in Asian American people. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Lim, Dr. Nguyen, and Jennifer Wild have to say about HBV care for Asian American people.
Hepatitis B is not a common disease in the general population in the US. However, it affects Asian Americans disproportionately. 1 in about 12 Asian Americans have hepatitis B infection. In fact, almost 2/3, 60% of hepatitis B infections in the US occur in Asian American people. And unfortunately, 66% of Asian American people with hepatitis B do not know that they are infected. Hepatitis B and liver cancer are the primary health disparities for Asian American people, and hepatitis B-related liver cancer is the leading cause of death from cancer in Asian Americans. As I already alluded to here, hepatitis B prevalence overall is low in the general population, but in Asian Americans, it is high, 3.4%, and it is largely an imported disease. The vast majority of chronic hepatitis B infections in the US occur in foreign-born people, in Asian especially, according to this study that looked at whole US population after sampling. So it is designed to represent the general US population. The hepatitis B awareness rate is actually really low, only 15%. So patients in this study are survey and ask anyone, any doctor, any healthcare providers, or anyone have told you that you have hepatitis B. If that you have a liver disease, not even specifically hepatitis B, and only 15% say yes. So this could be due to that the patient have not been diagnosed with a liver disease or hepatitis B specifically, or that maybe they've been told, but they forgot that they have a liver problem. But the end result is that if a patient or a person is not aware that they have a liver problem or a liver disease, then they are unlikely to go seek care for it. And the treatment rate for hepatitis B is only about 5%. Now, not everybody with hepatitis B needs to get hepatitis B treatment. However, the estimate is about maybe 20 to 30% of the patients with hepatitis B probably would meet treatment criteria. So this 5% treatment rate here represents a very severe undertreatment of patients with hepatitis B. And that undertreatment, diagnosis rate of hepatitis B shown in the Epidemiology population survey is somewhat confirmed by this real-world study in the US. So this is a database that includes 198 million US people with private insurance. So these patients have insurance coverage. And estimating the data from this, we estimate that only about 18% of patients with hepatitis B have been diagnosed. So it's fairly close to the 15% unaware of liver disease rate seen in the population epidemiology survey. And the other thing is that we found that if the people with private insurance are so underdiagnosed, like 80% have not been diagnosed, then you could extrapolate to the populations who do not have insurance or underinsure would be likely to be even worse. So it's a severe problem. So what are some of the key challenges to hepatitis B care in general and in Asian American people? As we just saw the data, financial reasons is maybe only one part of the problem, because we saw a very severe underdiagnosis problem with the population with insurance, with private insurance. So some of the barriers can be culturally-driven belief system, stigma related to hepatitis B infection. Some of it may be related to knowledge barriers with language and health literacy barriers, because the vast majority of hepatitis B infection in the US are from foreign-born people, and the large majority of these are Asian American, but also there are a significant population of Hispanic, Mexican American, and non-Hispanic Black people with hepatitis B, and people come from very diverse cultural and belief backgrounds and language backgrounds. And then going back to financial lack of insurance coverage or access to care. Now, having insurance coverage does not mean that the patient have good access to care. Some insurance coverage may be suboptimal coverage, or someone with insurance coverage, but they don't live in an area that is near a place with an HBV care provider, or that they have language or stigma barriers to access the care that they need. So with that, I would like to transfer this now to Professor Lim to discuss with us more on HBV-related stigma.
Thank you so much, Dr. Nguyen. I think that this provides some really important context for what will be a focus for today's program, which is really diving into the patient experience as well as the key barriers that impact the care of hepatitis B among Asian Americans. And so I think what we hope to do is to dive into some of the key issues, the first of which is stigma. So with regards to HBV-related stigma, I think that one of the most common reports that I receive from patients is that they feel significant emotions related to their diagnosed hepatitis B, largely which relate to that sense of guilt or shame, or having impact on themselves, their family, and other loved ones. In this first study that we report on this slide, this gives us a sense of the experience in a Vietnamese population in Chicago. Now, and in this survey, respondents were asked to address the frequency in which they experience very specific perceptions about themselves or among individuals with chronic hepatitis B infection. So in the left bar, you can see here is that what we're describing is quite startling and sobering. So that the hepatitis B diagnosis may have an impact on one's view of being a desirable or undesirable spouse, being able to be trusted as a friend, trust not to bring harm to others, the need to be isolated, the shame of having a sexually transmitted infection, the need to avoid close contact with others, placing others at risk for hepatitis B, the fact that they feel that may be bringing trouble to their own family, the feel of guilt of having this infection, and a general sense of shame about carrying a hepatitis B infection. It is striking that nearly 30% of patients experience guilt or shame about their diagnosis, and particularly related to a sexually transmitted infection. And I want to highlight two that I found to be particularly striking, is that about 25% of individuals felt that individual hepatitis B would be an undesirable spouse, and that among individuals who have hepatitis B, 28% report that these individuals may not be trusted as friends on the basis of having hepatitis B infection. And so I think this really helps to underscore that carrying a diagnosed hepatitis B has meaningful effects on the individuals who are infected with hepatitis B, as well as perceptions of others of these individuals carrying hepatitis B infection. It has meaningful effects on one's sense of wellness and directly impacts relationships with others. And I think furthermore, we see evidence that over 40% felt that patients with hepatitis B should avoid close contact with others and or need to be isolated from others. Now, this is just one survey in a very specific population in Chicago, but I think it's quite reflective that we see in other studies in Asian Americans of very similar themes. One study of 150 adults from San Francisco, the majority of whom are US born, and the same themes of concern about isolation from friends or other loved ones, as well as ability to obtain a job or potentially impacting their employability long term. In a second study, Asian Americans in Michigan, the vast majority of whom were foreign-born, the similar themes of the potential need to avoid contact with others and impacts on employment. And in a third study of Asian Americans in Chicago, the majority of whom were foreign-born, we again see issues related to stigma and the fear of placing others at risk for hepatitis B through close contact. And so we see very clear themes from these survey studies, again, confirm that stigma is highly prevalent among individuals who carry the diagnosis of hepatitis B and has a significant impact on social relationships and concerns with employment. Beyond the individual and on the individuals who are in close social contact with persons with hepatitis B infection, we recognize that there are additional institutional barriers that contribute to stigma. And I think that among the barriers that have been clearly documented in the literature are the levels of schools and universities and by employers. And so I think in the context of schools and universities, there have been multiple cases, both here in the United States and other countries, where the hepatitis B status is specifically solicited in the evaluation process for university admission and has directly impacted their ability to matriculate at university. And furthermore, particularly in certain countries, particularly in East and South Asia, that hepatitis B status is a specific question that directly impacts their ability to be hired for their job. And I think reflecting this is that there has been the need for specific legislation and policy to mitigate against this discrimination based on HBV status. And so a couple examples here from China, a high prevalence country for hepatitis B, had to pass anti-discrimination legislation in 2007 to end discrimination against workers with hepatitis B with termination of employment. And in 2010, banning testing for hepatitis B prior to enrollment in schools or for jobs. A more prominent case here in the United States in 2013 was an example of a medical student who was admitted on merit to a medical school, but based on HBV status was denied the ability to enroll and matriculate at this university. And this ultimately led to a Department of Justice case and leading to formal policy that identifies chronic hepatitis B infection as a protected condition under the American Disabilities Act. And this is a really important legal protection against individuals with hepatitis B experiencing discrimination by universities and or employers. So the question then is raised, how do we actually address this issue? Because this is far beyond the medical realm and requires a broader-based, multi-stakeholder approach to overcome these barriers. I think that what can we do as clinicians to address this issue? Well, number one is that we should take aggressive steps to open the door for conversation with our patients with hepatitis B, to try to identify what is their individual experience. Are they experiencing stigma, anxiety, and fear about discrimination? Are they actually experiencing real discrimination in their schooling and or education or workplace on the basis of hepatitis B, and serve as important advocates to mitigate against these issues? Second, we do want to make sure that we do our parts to create educational activities and content that are culturally and linguistically appropriate for Asian Americans and the communities that we serve, specifically related to hepatitis B. How is it transmitted? How is it not transmitted? What is the experience of those living with hepatitis B? And what are the things that can be done for monitoring and treatment? And I think if we have a broader-based education, not only of individuals with hepatitis B, but the broader community, particularly in Asian American communities, it can help to dispel the many myths that persist regarding risk of hepatitis B transmission between individuals. Third, I think we play an important role as clinicians to serve as advocates for changes in policy and regulations that protect individuals with hepatitis B and provide them support that they need to feel that they're able to move on with their lives, their schooling, and their work without feeling discriminated on the basis of their infection with hepatitis B. And finally, I think we as clinicians can play a role in facilitating the involvement of our patients in various social support groups and community groups, networking groups. So there is a stronger sense of community about how we individually and as a community can advocate for these important changes. So at this time, I'd like to turn this over to my colleague, Jennifer Wild, for initial discussion.
Thanks, everybody. I think that some of the information here, even though I'm a clinical nurse, I have not heard some of this before. So I want to maybe talk about some of it. I think one of the most unsurprising, but just emotionally effective pieces of data was just seeing that bar graph with the way that patients can react and feel guilty, and the way that graph also highlighted some knowledge disparities too about risk. What would you both say, and we could start with Dr. Nguyen, what would you say are perhaps some of the family dynamics with guilt? Because that, for me and my patient population, is a very recurring theme, guilt towards others in the family.
Yeah, I would agree with that being a pretty common occurrence. And some patients approach you and ask you about it, and some don't. And now, as I am reflecting here, I'm thinking that, maybe it's something that we should bring up more instead of just waiting for patients to bring up. So in the occasions that the patient brought up with me, it's about like my husband or my children have been vaccinated. Can I still give it to them? Like if I don't take medicine, if my virus level is high, am I more likely to give it to them? So I think that, in our role as care providers or advocates, we can help provide the knowledge because those concerns are not necessary. So I generally would tell the patients that if your spouse and your children or your household have been vaccinated and have immunity against it, then it really does not matter, whether your virus level is high or low, they should be protected. And, suggest to them, if you really want to be sure, you can ask them to just have their blood test checked to make sure they have protective immunity. And then that way, you don't have to wonder about it ever again. They are protected. So, because some patients, if they do not really need, if they have mild disease, they do not need medication. We do not want them to feel that they, have to take a medicine just to protect the family when it's not necessary. Of course, when they meet treatment criteria, if they have active disease and should be treated, then that's a separate story. I also often hear another sort of like stigma and guilt from actually many patients, not even people who are not my patients that just met me at conferences. They would usually come at the end and ask me if they could ask me a question. They said, my mother does not have Hep B. Nobody in my family have Hep B, but I have Hep B. But I've never been sexually active before. How can I have it? Because then that could also be another stigma. People may think that you either get from your family or you get it from, having multiple sex partners or something like that. So I explained to the patient, and I try to make a point to emphasize this when I give lecture on this topic, is that a lot of hepatitis B infections from endemic countries such as Africa, Eastern Europe, or Asia, the infections are horizontal during early childhood because of just, from interactions during school or exposure to share needles by vaccination that occur a lot in these developing countries. So that also a misconception that health advocacy, health advocates and physicians can try to educate the public and the patients so that the Hep B patients are not stigmatized.
That's a great point. I'm Dr. Nguyen's patient for my chronic Hep B, and when I think back to when I was first diagnosed and I had only just become an RN, I had only just passed the boards like 2 months before I was diagnosed. And I think back to what little knowledge I had about this at the time. It is very confusing, and every person is different. Every person reacts with different feelings and emotions, for sure. Dr. Lim, your thoughts?
Yes, absolutely. I agree entirely with my colleague, Dr. Nguyen. Just two small additional thoughts on this. The first is that there remain important myths about HBV transmission that has been highlighted. Things as simple as sharing utensils, drinking glasses, chopsticks, hugging, kissing. And I repeatedly hear stories of patients who have been shunned socially because of these concerns. And that's part of our obligation as clinicians to educate not only our patients, but their family members, their caregivers, and our broader community to really highlight that these are not routes of transmission, that it's actually quite difficult to transmit except under very specific circumstances. The second thought is that one thing that I've seen in numerous situations in a way that's very emotionally driven are relationships, particularly among those who are in a relationship and or our fiance or spouses. And I've had numerous cases where one individual has known hepatitis B, the other does not. They are thinking about getting married, and it becomes very emotional because sometimes there hasn't been a disclosure of one status and how we can get around that. And I remember sharing with an individual that was one of my patients and her fiance how this is something that we can deal with, we can test and vaccinate, immunize. And I could just recall the tears flowing down their faces just because they felt that there was a path forward, that this is not by any means a death sentence, that there are things that can be done both for the individual with the infection as well as for the individual who is his or her partner. And I think that's, again, an opportunity for teaching and education and support, and really recognizing what are the unique needs and concerns and anxieties for our patients and make sure we can support that.
Definitely, yeah. And we're really fortunate that we live in an era when we have an effective vaccine. I do think because it's a 3-series vaccine and the possibility that some people don't complete the series, I just want to emphasize what you both have already said, and that's to get the immunity checked, to do the antibody titers for those family members or friends or partners who maybe were already vaccinated, but just to ensure the immunity status. I do know some patients who have finished their vaccine series and they get diagnosed with chronic Hep B and they say, how was this possible? And of course, the presumption is that they were exposed at a very early age in early childhood or as an infant or newborn. But, it's something that everybody, I think, who is potentially at risk of exposure should verify.
So the next section of our session today is on language barriers. So language barrier is specific and is not really dependent on just educational level. Level of education is one thing. Health literacy is another part of it, and these things are not interchangeable. So regardless of level of education or length of residence in the US, language may remain a barrier because you cannot always literally translate word by word and expect the meaning to be the same. And some of the more technical words, for example, the language, there may not be an equivalent term in the patient's home language. And I could speak for this myself. I am bilingual in English and Vietnamese. I have many Vietnamese patients, and I do my best to explain and translate into Vietnamese what I would like to educate the patients. But a lot of time there are no equivalent words. And sometimes when you try to find quote unquote exact word by word, it would actually sound kind of funny and the meaning actually may be totally off. So I think it's very important to recognize this and use language that is understandable and culturally sensitive to the patients that we work with. And not all Asian origin languages are supported by, interpretation or translation services too. So that is the other issue. I'm from the Bay Area, so it's more than 30% of the population here Asian. So it may be easier here to find interpreters for the main groups like Vietnamese or Chinese, Mandarin or Cantonese. But if I need an interpreter for a patient from Laos, for example, it is harder to find sometimes. But for the more uncommon languages, AT&T operators we can access, but it's not as good as an in-person or video person. But these are things that we really need to pay attention to. The effects of language barriers is very important. the patient may feel that they are not being understood and feel alienated from their healthcare providers. They may have problems interacting with others or is afraid of being misunderstood. And that may eventually leads to a lack of trust, and late alienation with the healthcare providers, and that would really impact the care. So what may be some of the solutions? Medical interpreters would be very useful, and as I already alluded to earlier, in-person and video interpreters, that would be easier to understand, and there will be more empathy, easier to have more empathy than just by telephone. And the use of family members as interpreters, if appropriate, if the family members are truly bilingual, and if it's agreeable to patient. And this can be, something to discuss further with Dr. Lim and Jennifer, because I know some healthcare centers actually discourage the use of family members as interpreters. Some even say that we should not use that. But family members are more likely to come from similar cultural backgrounds, and the family member would be there and may be helpful more than someone who may be speaking the same language. For example, Mandarin. Mandarin is spoken by people from mainland China as well as from Chinese immigrants from many other different areas or from other neighbors such as Taiwan or Hong Kong, etc. So someone who speaks the same language is not necessarily have the same exact cultural background too. So that is something to consider. And educational resources that are culturally appropriate. And I think from my experience, one of the most useful way to overcome some of this is to have bilingual, multilingual healthcare professionals. I go to an outreach clinic in the South Bay of the San Francisco area, where many patients are immigrants from Asia, from Central South America. And the staff in that clinic, many of them, almost all of them are bilingual. And it's so helpful. The patient just feel comfortable just walking into that clinic, and they know they can speak directly to someone there, versus in the clinic where the staffs are not bilingual or multilingual, that they would have to call in an interpreter. And many patients seem to also be hesitating to request interpreter. Some maybe to fear of bothering other people or some other kind of fear. Because I have had patients that would decline interpreters, even when I asked if they would want, and I could see that the patient may have a little bit of struggles with the language, but people would decline sometimes. So mobile app is very useful. I see some patients use that, and they use it with me too, because they can translate. Many apps will translate, or they are not sure what word, and then they use the app to translate it and show me. So we would need to be creative in how we communicate with our patients, but bilingual, multilingual healthcare professionals in the same clinics is something that I would strongly advocate for. And I will turn this back to Jennifer to help share with us some of the perspectives, from your perspectives, as an ally healthcare professional and a patient in this field.
Thank you, Dr. Nguyen. Yeah, you're absolutely right that different regions of the country have, different diaspora communities. And so it may be more or less challenging to find an in-person interpreter at your facility or at your clinic, to those learners listening out there, at your location. I think perhaps when available, some third-party language interpreting services that offer a wide menu of languages can be very useful. It means that you don't have the interpreter in-house through the organization, but through a third party. But I realize there can be cost with that. Dr. Lim, what has been your experience? I understand you practice primarily on the East Coast. What is it like with your community there?
Absolutely. So we are fortunate that we have really strong language interpretation services, both live in person, but also through video and as well as audio phone as well. And I think it always is a balance. Our institution is one which has a very strong preference for the use of formally trained medical interpreters rather than the use of family members or staff. And I think that Dr. Nguyen very importantly highlighted that there can be a higher level of trust and comfort level when you use a family member. And I think that it's always a judgment call for us as clinicians is determining what might be appropriate for a given patient. That being said, I have learned that sometimes family members may have specific biases about what his or her family member can handle, particularly when it deals with difficult diagnoses such as liver cancer due to hepatitis B. And I've had cases where, either a medical student or medical resident or fellow working with me that shares the same language capacity reveals that that what's actually being communicated to the patient by a family member may not always be fully reflective of what we're trying to communicate. And so I think that there is a balance in terms of how that is managed. And I think that's something where just having a sense of what's appropriate for individual patients is helpful. The only other comment I would make is that one thing that I found to be useful, because I recognize that after I've tried to communicate and it's translated, sometimes it's hard to get really good feedback as to what the patient understands. And so one thing that I've done on a routine basis is ask the patient to reflect back what is their understanding about what we've discussed regarding our treatment plan or prognosis, et cetera. And that has been really useful for me to just make sure and double check that what we're communicating, what they're hearing and understanding is the same.
That's a really good point. In many languages that come from the Asian region, there's a word for a respectful agreement. It's like it directly translates often to yes, but it's not always actually yes. Similarly with no's, and so I agree that's a very good point to bring up. And the family dynamic, again, I think this is perhaps a recurring theme in today's discussion, that the family is often a large part of all of this, not just the guilt, but also the protecting sometimes that the family interpreter wants to provide. Dr. Nguyen, did you have anything else to add? You had peppered in quite a few things that would have applied to the panel discussion throughout the didactic.
I just wanted to highlight what Dr. Lim mentioned earlier about the use of interpreters, family versus non-family. That's a really important point. And this go back to, again, the cultural belief. I have had patients, because I am fortunate that I am bilingual, so I can communicate directly with many of my Vietnamese patients. And I've had many family members come up to me, and because they know that I can understand Vietnamese and I can speak Vietnamese directly to their families, right? So they would say that, ask me, don't tell the patient that the patient has cancer, for example. So then I would have to spend time to try to convince the family, to let me. I said that, no, I cannot tell the patient have no cancer when the patient does, but I will promise to say it in the best way possible, so that things can fall in stages and give support, to the patient, and also try to convince the family too, that from my experience, patient knows more than you think. And I tell the family, the patient have cancer, most patients would feel there's something in their body is not right. The patient knows. So, and many patients told me themselves that, though Dr. So-and-so told me I'm okay, but it's my body. I know that the cancer is progressing, that the doctor was just trying to make me feel better, And fortunately, so far, I've been able to convince the family, that the patient knows anyway, whether you think the patient knows or not, and eventually will know. So it's better to let the patient know, but you would say it in the most supportive way and provide support. So I want to share that, because that actually is not uncommon at all. I've had this many, many times in my career.
You're absolutely right. Yeah. In the cancer center where I work, I have seen it go both ways, because Hep B and liver cancer are often co-occurring conditions. I have often seen family decide, we're only going to tell mom about this one or that one. We'll just say it's just this one. We'll just say it's cancer, or we'll just say it's Hep B. But I often see them make a choice about which one do we focus on. We don't need to tell mom or tell dad about both. It's really interesting.
Okay, so I think our next topic is that of navigating health insurance. I think we all recognize that to provide quality care, that it's important that there's access both to the diagnostic tests, the tests that help to evaluate and stage one's disease, have access to antiviral therapies if and when appropriate, as well as the other tools that are necessary for long-term monitoring, such as imaging for liver cancer. And so I think that there are important barriers within this realm. I think that patients without health insurance, it's a little bit more obvious that having the financial resources to cover the costs of these tests is very, very challenging. And therefore, there's an important opportunity to identify whether patients may be eligible for insurance, what is their immigration or citizenship status in terms of identification, as well as issues related to language and literacy to access those resources to obtain health insurance. For those who already do have health insurance, some of these same barriers apply, including language and literacy in terms of how to not only access health insurance, but how to utilize it in the way that's necessary to receive the highest quality care. And this includes being able to identify a medical provider, particularly those that may have the cultural and language capacity, but also the specific experience in the care of patients with hepatitis B, as well as being able to navigate the very challenging spectrum of tests and providers for the different elements that are required for care and where you receive care, whether it's in-network, out-of-network. These issues can be very challenging for anyone to navigate and to do so in a way that goes beyond the language issues. And finally, in terms of being able to determine and access treatment, I think this is also an issue where even with those with health insurance, whether it's Medicare, Medicaid, or commercial payer, there are substantial differences in terms of prescription drug coverage and out-of-pocket expense. And being able to navigate that particular challenge is important. How do we overcome these barriers? So I think first, for those who are not currently insured, I think one of our responsibilities as healthcare providers is to participate in that process of identifying individuals within our own offices and our social workers to help patients get enrolled and to see what they may be potentially eligible for within their state. I think in many states, there are access to health exchanges that are agnostic of specific citizenship status. And I think that's important to determine what our patients can access, because it's going to be very important in the care of any patient to have adequate health insurance to cover the costs of the different elements. Second is that when available, make use of health navigators or care navigators. They can be incredibly valuable partners in partnering with patients and helping to navigate this entire process, about to go through the referral process to get specific services, linkage to care providers with experience in the care and treatment of hepatitis B, to access the medications if and when needed for antiviral therapy, as well as social services, particularly for those who have very specific care needs related to hepatitis B and its complications. And then finally, obviously, in addition to trying to access medications for hepatitis B when possible and as appropriate medically, to be able to access generic antiviral medications. It is obviously very difficult to be able to account for the very wide spectrum of barriers when it comes to healthcare access, particularly related to health insurance, as well as access to medications. However, I think we do want to provide at least a few resources that we have found to be very, very useful and valuable that might be helpful for you and your patients. So first, our patient assistance programs. So this is a website from the Hepatitis B Foundation at hepb.org that is an incredibly rich resource. It's probably the best curated website that I've seen that gives you a lot of detail about very specific programs for patient assistance, copay assistance, online pharmacies, as well as discount cards to access prescription drugs. And so this is, I view, as a go-to site for patients. The second is the Prepare Toolkit. This is something that can be a very useful document and resource guide that has a specific area that's focused on insurance access for antiviral treatment. Third is that each state has slightly different policies at the level of either fee-for-service or managed Medicaid, Medicare, and or commercial insurance within each state. And obviously, it's impossible for any clinician to just know all those resources and all the intricacies. And so one thing that the American Liver Foundation has created is a resource guide that is state specific, that can be a useful tool so that wherever you are located and wherever you are practicing, that you can access this and potentially give this to your patient and partner with them to find those resources that are local to you. And then finally, there's a patient navigation program. There are similar models in multiple states. This website is one that's specific to New York City region that helps patients to get linked to care for hepatitis B, particularly in areas that may have specific cultural or language capacity that meet the needs of your patient. And so at this time, I'll transition back to my colleague for our discussion.
Thank you. I think financial toxicity is a major part of the delay in diagnosis. I can think of many patients over the years who I've had who did not know they had Hep B until the day they were also diagnosed with liver cancer. They get both diagnoses at the same time, and it's only because they present from symptoms related to their cancer progression. And so it brings up the question, how does one know if they have Hep B if they aren't insured and they don't, perhaps, even if we inform them of the possibility that they may be because of their demographics and their endemic place of birth, do they want to take the potential financial cost of getting an insurance plan to do the testing if they maybe don't have Hep B? And so identifying what the options are for screening and testing in your area, I think, is really important for some people. I know that in San Francisco, there is a liver task force through our public health department, and they do provide free screening for Hep B and Hep C for anybody, regardless of insurance or housing status. And there are other programs similar to that in many parts of the country, but I'm sure there are areas that are not as well supported. And so definitely having those colleagues and navigators and clinical social workers who can help navigate what are the insurance options for this person? How do we get an application in to get coverage for this person are really important conversations for patients to have even before maybe they reach care for treatment, that is. Dr. Nguyen, what are your thoughts on some of this?
It could be because, I'm in a clinic, right? So people who come and see me already have a diagnosis. But as you could see from the data that we study from the, the US data, it covers 198 million US people. So it's almost the entire US people with health insurance, right? And the diagnosis rate is still very low. Now, the test for hepatitis B diagnosis, the hepatitis B surface antigen, is pretty inexpensive. And that should be covered by insurance if patient have any kind of insurance. So I think that for the diagnosis, the problem is only partly financial, but maybe it is more of stigma and other things, lack of knowledge. Maybe patient didn't know that they should be screened. Maybe their doctor didn't think that they should be screened and didn't screen them. So I think it's quite complex in regards to HBV screening and diagnosis by itself. But certainly removing the financial barriers is very helpful. And as you and Dr. Lim already mentioned, many cities, and counties and have some kind of program that hepatitis B testing can be free. In California, recently it was passed that testing for hepatitis B should be covered. What I guess I have seen more, and the bigger part, is about the drug coverage and the blood test coverage.
Yes.
So having insurance doesn't mean that everything is paid for. And insurance is so complicated, and I am embarrassed to admit that, I hardly understand my own insurance coverage, because one year I can go get tests and I don't get any bill. And one year I would go get tests and I would get a bill for some copay. So it's very variable in terms of the insurance. So the complexities of our insurance systems is a major barrier, even in people who are insured. Because for me, sometimes people may be afraid to get it because they're not sure how much is covered and how much is not. So I have patients who've told me that to get an ultrasound for liver cancer screening because they have hepatitis B, some patients say they pay nothing. They don't get anything, totally free for them with their insurance. Some patients told me that they are billed for the whole cost of the insurance. So it could be a variety of things. In some patients, maybe because they have to pay and up to an amount, let's say 3,000, 5,000 before the insurance would kick in. Some plan is like that. They have a high deductible or they have a high copay that they would have to pay 70% of the cost before insurance would kick in. So insurance is really a big barriers, I think, for a lot of the monitoring care as well as medication. Medication for some patients, it's like they don't pay anything at all. And for some patients, despite insurance, they have a big copay. And one interesting thing is that we may think that having a generic drug is good. Not necessarily, because recently I've had patients who want to be on a brand medication because that brand medication have a coupon. Even though it's higher, but whatever their part is, they can get a coupon or patient assistance program from the maker of the medication. Whereas the generic, the market price may be 20% less than the brand medication, but the patient doesn't get any assistance for their copay. So they would end up paying a lot more for the generic. So it's really complex and it really requires a care provider to really be aware of all of these things.
I think that uninsured and underinsured are two very different, but perhaps equally as impactful kinds of financial toxicity. And all of these things speak to a larger systemic issue that the three of us and this didactic are not able to solve. But I think having the conversations go back to part of the didactic that Dr. Lim talked about, which is about promoting policies and changes in the healthcare system to improve the care that our patients ultimately get and the rights that they have under the law. Dr. Lim, what has been your experience with financial toxicity in your patient population?
There's a lot that we can talk about, but very briefly, I think that there are many examples where even insured patients have significant barriers to access. I've had patients where the insurer approved a prescription of a given antiviral, but with 100% copay, which basically is meaningless because that means that the patient still has to pay for the whole cost of it, right? It's very meaningless. And I think that's my two words of advice, I think, is number one, working with specialty pharmacies when possible, where they can really investigate as thoroughly as possible what are the options available for branded or generic medications, what is going to be the best possible outcome for the patient and limit out-of-pocket expense. The second is that when we're available, 340B programs sometimes can be a real partner and friend for patients and sometimes may be able to provide a free or very low-cost antivirals for hepatitis B. And of course, that is really dependent on geography. But I think the other factor, which I think is beyond scope of today's discussion, is covering all the other costs related to hepatitis B therapy, particularly when it comes to high-cost procedures such as CT scans or MRIs for hepatitis B-related liver cancer. And that's a whole different ball of wax. But I think that the principle for us is that we really want to be really strong advocates and be able to negotiate with payers to ensure that the best possible care is provided.
Absolutely. And it's not that we as advocates or as providers can solve all these problems, but ideally we have teams and resources that we can reach to. And so I hope that this didactic is one of those resources. I hope that people also reach out to their colleagues like licensed clinical social workers, specialty pharmacy, as you mentioned, Dr. Lim, can be an excellent resource. And of course, patient navigators too. For the sake of time, I feel we have to wrap up. I feel there's so much more we could talk about. There's so many more patient experiences that I would love to share, but perhaps that will be for another session some other time. I want to thank everybody here, and I'll hand it over for the wrap up.
Okay, so I think that we had a wonderful discussion about some of the more common barriers to care of patients with hepatitis B. There are obviously many other barriers, and so we highlight just a few. First, our spiritual or religious beliefs. I think that there's an understanding that how one views their own health and wellness, well-being, and how they interact with disease and illness varies dramatically based on cultural context as well as religious beliefs as well, and trying to identify that and trying to work in context of an understanding of where a patient is coming from, I think is part of our obligation as clinicians so that we can provide the most sensitive care that we can. Second is mistrust of the healthcare system. This is increasingly prevalent, particularly in context of the pandemic. And I think that's part of our role, is to continue doing our part to be good educators, but also to be sensitive to the fact that there is a reason why there's a mistrust of healthcare providers and education. There's a long history behind this, and I think that we can do play a large role in trying to dispel some of these concerns and hopefully be able to build that trust with patients, at least on a case-by-case basis. And then number 3, I think one of the more common issues that we face is that many of our patients, particularly those who are Asian American background, take over-the-counter medication, supplements, herbal remedies, and taking a medication history, unless you specifically ask about it, they often will not volunteer the information. Do you take any medications? No. Do you take any herbal remedies? Yes, right? And it's something that we have to specifically query. And we recognize that some of these may either have potential for hepatotoxicity, and others may have potential for drug-drug interaction with antivirals or other prescribed medications. And so it's something that is part of good clinical practice, is for us to specifically ask, identify, educate, and when necessary, to make changes so that it doesn't impact their liver care. So in conclusion, I do want to just highlight a few what we view as take-home points. First, Asian Americans are disproportionately affected by hepatitis B, with significant disparity in not only the prevalence of chronic hepatitis B, but hepatitis-related complications such as liver cancer. There are many barriers to hepatitis B care. We highlight just a few, including stigma, language and health literacy, and insurance. We identified several of the solutions that can begin to overcome these barriers, including increased awareness, education of patients and providers, and the use of culturally and linguistically appropriate educational materials, very important. And finally, trying to navigate the health insurance system using the resources that are available.
I'd like to thank Dr. Lim, Dr. Nguyen, and Jennifer Wild for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on HBV care in key communities, minimizing barriers and optimizing care, on the Clinical Care Options website, click on the links in the show notes for this episode. Other key communities addressed in this program include African immigrant communities, people of childbearing potential and their infants, and older adults. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.